Ladies and gentlemen, it is a great pleasure and honor to welcome you to this first session of the afternoon where, alongside my co-chair, Luca, Cordaro, and three magnificent panelists, Nitsan Bichacho, Ramón Gómez, and Florin Cofar, we are going to be continuing the discussion on time around implants, but we're going to be focusing a little more on treatment planning in full arch reconstructions, how it is that we can reduce times achieving optimal outcomes. And before we do that, similarly to what we said last year, it's important to go back to what Howie showed us this morning. And the fact is that when we have cases like this, more often and more often, we're seeing abrupt destruction of what we encounter. We see cases often now where teeth that are in very good conditions, should I say, are mutilated and taken out, not only just the teeth, but even bone destruction and taking the gingiva out. I think from the EAO we have to make a stance. Luca, what do you think? And say that this is definitely not the way we'd like our profession to proceed.
Well, this is clear, I think, to everybody. We are here dentists, all of us, or I think most of us. Our first job is to save teeth, not to extract teeth, for sure. Of course, when you have compromised dentition, extraction of the teeth that is, or of the tooth that is not completely compromised can be taken into consideration to make the restoration more reliable, maybe more simple and more effective. But if you have a case like this, I mean, it's criminal to my understanding to extract everything, resect the bone, and place the implants, and do a FP2 or FP3 restoration. Mostly because you're not giving the patient a second chance. This is what I think we have to keep in mind. It might be not our problem, because maybe this will happen in 15 years, but when you resect the bone like that, in a case with, you are then eliminating for the patient a second chance to have a decent rehabilitation.
I have no doubt that our panelists today are going to show you exactly what teeth to save and how to do this to optimize time, but at the same time, leave a beautiful, long-lasting outcome. Ramón, may I have you on stage to cover the limits of full arch reconstruction?
Thank you so much.
Pleasure.
Thank you so much for the kind invitation. A pleasure to be here sharing with my two colleagues. And I was told to lecture today not about the workflow, but the limits and the digital workflow. I think every day we keep learning more and more about how to overcome these limits. This is the workflow I published recently. I've been using for almost the last decade, based on milling or printing the provisional, because basically I'm too lazy, you know, and because I ended up quite fed up of relining, you know. But I'm not gonna speak about this. I'm gonna speak about the limits, as I said, and I could distinguish four different fields: the health and age of the patient, in order to tailor the treatment. Every patient is different. The bone quantity and quality can be a challenge. The soft tissue condition, as my previous colleague said, Dr. Bichacho, and biomechanics. He already mentioned how important it is. So first clinical case I bring here for you is this one. I think most of you agree that a good treatment plan would be to pull out the teeth and to go for full arch rehabilitation in the upper and lower jaw. And this is the result 8 years later. So we don't really know where the limits are yet. And this is the treatment. I didn't put one single implant. And this is 2016-2025. And it means that periodontal treatment works. I don't mean putting here implants could be a wrong treatment. But thinking about the limits, look at the proven death after 8 years. You know, of course, we have to consider the age of the patient, the compliance, many other things. I cannot do this in every single patient. That's my point. But we got success because this is a good patient, and I think it's worth it to preserve this teeth. In other patients, I want to speed up because this lady is more than 80 years old. So it doesn't make sense to go for FP1 in this lady. I want to speed up, and the way to speed up is digital workflow. With photogrammetry, I can speed up a lot, and I go from here to there, extracting the canine and avoiding bone augmentation. Not because I'm not comfortable with it, because it would be a high morbidity. It would imply a high morbidity for the patient. But in other cases, that's different. This man is around 40-something. This is the 5th time someone is going to put implants there. So I reconstructed the bone all around the zygoma implants and into the sinus and the soft tissue as well. How do I overcome the limits of digital workflow? Manufacturing, milling this PMMA tiny piece in order to overlap the files, and I screw the piece onto the palate before opening up the flap. In cases where I need to raise a big flap, this is the way we do it. And then I take the intraoral impression, but photogrammetry as well, because you see there is a long distance from one implant to the other. And then the patient was having breakfast the next morning with the dentists who were shadowing me. So, and without paying anything like that. So I went, and I think that all of you agree that the best way to guarantee a good prognosis here is to have a fixed prosthesis, not a removable one, for the hard tissue healing, but also for the bone grafting and the vestibuloplasty, because as Dr. Bishaso said, I need not only quantity, but also keratinized tissue all around. And then I went from here to there. Afterwards, we changed the crowns in the lower. So every time I see a patient like this, of course, the first thing I have to do is to look at the face, because everything is facially driven. In some cases, I don't even have the possibility to go for FP3. Maybe I need an overdenture. But these are the determinants, the vertical dimension, where the transition line, the transition area is located. Do I need lip support? Because if so, maybe I need an overdenture. And maybe in some cases, all patients, complex cases, bone reduction is an option. But in other patients nowadays, because we know much more, with not so big defects, with a better condition, reduced vertical dimension, highly blind, a patient with high demands, ideal lip position, younger patient, I can preserve or even reconstruct the hard and the soft tissues. So I take all of it in consideration. I think my friend, Dr. Cofar, is going to be speaking about this, and you will understand much better. But I bring you this case. Look at this. 20 years ago, when I was a young dentist, I couldn't dream of treating this case with a full arch rehabilitation and more or less FP2 or FP1 result. But now we can boost the tissue condition. And look at this, how much bone do I have? So what is the option? To pull out the teeth, to delay the implant placement, and then what? What do I have in 6 months if I put a removable denture here? So I want a fixed prosthesis here. I put my implants. Of course, I boosted the gingiva, and look at the healing only a few days later. So I am saving time, cost, morbidity for my patient, and I guide the healing of the soft tissues. And then this is the final result. In a patient with advanced periodontitis, something that in the past was published fully unpredictable. Now we changed things because we know much better how to, we modify the protocol boosting the hard and soft tissue condition. But is the same in every patient? Of course not. I don't graft every situation, every single situation. Look, sometimes I have so much bone and soft tissue, but how many patients a year? Other times, I need CTGs. And in some cases, the defect is so severe that I need much more. So decision taking for me is important. Not every case can be done in the same way. So this is the easy case. Throughout extrusion, I have tons of bone and soft tissue. So I can end up with this result without CTGs, because I'm pushing apically the gingiva. This is the easiest. And then I go throughout the digital impression, and I finalize quite quickly. But, of course, I wish every patient of mine was like this. But this is not in real dentistry. On Monday morning, I don't have patients like this, you know. And I have patients like this. And some of them, I can go flapless. Some of them, I cannot, because the condition is even worse. So mild defects, I go flapless. Look at this. And I load immediately, of course. And several CTGs. I cannot go deeply into the reasoning. But I ended up in no time. Only 3 days later, look, the soft tissue is creeping, is filling the embrasures. And finalizing. Okay? And 8 years later. But look at the other case. No bone between the central and lateral. Gingival recession. Advanced periodontitis. No way. This is more challenging. So, and I need sinus lip procedures. Bone grafting from the tuberosity. You know, to reconstruct the proximal bone fully gone. And I want to immediately load the implants. Not only to put the implants there. Because if I load the implants immediately, I guide the healing of the soft tissues. And I'm saving tons of time. Morbidity, cost, everything is much better for me and the patient. So I went from here to there and I loaded. I printed, no relining. The machine is working for me. I take advantage of the new technologies, new materials. And then I went from here to there. Maybe here FP2, because this is very challenging. Okay, not the perfect papilla, but I don't need it in every patient because this is a patient with a low lip line. But every single patient prefers this than a hybrid denture. And Dr. Richacho just said, hybrid dentures are challenging regarding the hygiene, you know. Some cases are even worse. I have a deficiency of the ridge, huge one. So I need overbuilding with a GBR. Soft tissue grafting is gonna fail here. Promise you, I've been doing it for 25 years, and now many people think that with the CTGs they can get whatever they want. No, you're gonna fail, because you check out the papers. You will lose 30–40% of its volume. It's too much the defect for that. So I need to overcorrect. And of course, the first thing I have to analyze is the face of the patient, the position of the incisal edge, and you plan everything. I'm gonna skip this because Dr. Cofar is gonna speak greatly about this. And the condition of the bone is very, very poor. Very thin phenotype. I place my implants and look at the overcorrection. More than 5 millimeters, and I need it in the posterior area, sinus lip procedures, bone grafting. Of course, I cannot load all the implants, no way. In many of my cases, I cannot load all the implants I place. But I can load some of the implants in the anterior area, 4 or 5 implants, and this is making a huge difference. And 3 of the implants are left there because I raised both sinus membranes. But I did all of it in one single step. Compare this with delay in the implant placement. How long is it gonna take? That's crazy, and without relining. This is the result of the milling machine. No working for 1.5 hours, no working for half an hour. The milling machine is working for me. You know, the technician is this redesigning the wax up to connect the wax up with the implant neck. And this is funny that in the lower jaw, this is the same patient. In the lower jaw, I did nothing. No bone grafting, no soft tissue grafting. Neither. I did, but in the upper, I did bone grafting plus CTGs. Why? Because this is the same patient, but condition in the upper and the lower, the condition is absolutely different. And then I ended up like this, like that. In the lower, everything was easier because I had tons of bone and soft tissue. And I went from here to there, and this is the result for you to see. You know, the final result, of course, after several months with a couple of provisionals, because we had to engage the implants we placed in the posterior area, and we didn't engage during the first surgery, we couldn't. Okay, more or less, that's The idea is splinting the implants because on the left I didn't have many. I lost one implant from time to time. I lose one implant because I take many risks, but it's worthy. Even so, it is very worthy. I don't have 100% success, but it is worthy. But look at this. We are able to get these results nowadays through hard and soft tissue boosting, something I was not able to achieve many years ago. And this is the condition of the gingiva 9 years later. That's my point. So this is regarding hard and soft tissue grafting. What about biomechanics? The less bone I have, the more implants I need, sometimes even pterygoid implants or zygoma implants or whatever. If you have a better bone condition, you can avoid many implants nowadays. Depending on the economical condition, you have, once again, to individualize every single situation. And we have digital limitations, but we learn how to overcome them. You know, scanning the dental loss arch is not easy. It comes with a mistake around, with an error around 150 microns on average. It means we need more things, for example, photogrammetry. Or you have to segment the arch. That's another option. And then I will need to select the proper material in order to treat every single patient. So here, some papers regarding this kind of problems we have, and we overcame years ago with photogrammetry. I'm not gonna go once. I'm not gonna explain once again what photogrammetry is, but here you can see a paper published this year comparing different systems and saying to us the photogrammetry is the way to go if you want to register with precision the full arch, of course, for a splinted prosthesis. The goal is to combine the photogrammetric file with the intraoral scanner to end up with a new precise digital model. And then I don't need any plaster, any articulator. Everything is inside the computer. And then you can manufacture the framework or the provisional without tie bases. That was my idea many years ago. We were able to do it, and that's the lovely way to go in full arch rehabilitation. That's how I treat my patients right now, because I save a lot of time. But of course, there are many other ways. We've been testing systems like this. For example, these are Apollo flags. There are many in the market. These are other scan bodies. You can avoid buying photogrammetry. They are maybe not so precise, not as precise as photogrammetry, but for sure you can produce good quality, at least temporary restoration. And then maybe you segment the rehabilitation, or you use other techniques, mixed techniques, in order to finalize your clinical case, because not everybody is interested in buying these devices. Okay. Finally, what is the material I'm using? And all of us are constantly talking about this. I tried a little bit of everything, PFN, of course PMMA for the provisional, and zirconia. And the problem with zirconia, you know what it is the fracture. And yes, not a high rate, but this complication is very, very bothering for us. And to have this kind of complication at the office undermine the trust of the patient on us. So how we overcame this, you know, because for FP1, because for the FP3, of course, the connector, that's the key point, is very thick, very large. I don't have that problem. But what about FP1? In FP1, sometimes we had that problem, and it cost a lot of money. So we've been using this kind of two approaches, you know, a framework, titanium framework, or lately a very strong zirconia framework. This zirconia is around almost 2,000 megapascals, you know, and it's bonded, it's hot bonded with a full thickness monolithic zirconia. In that way, I avoid the fracture of the framework, I get aesthetics, and I don't get chipping. The Decision taking will depend on the number of implants you have. Imagine you have few implants. This option, not to splint, maybe is not feasible if you have 4 implants. The lab expertise and the zirconia type you want to use. And you have more and more evidence about this. Let's see what the future comes, because now the long-term evidence is not strong, but it's promising. It's promising. But not everything is an advantage. Of course, this kind of rehabilitation is very resistant and is aesthetic because we have a monolithic zirconia over the titanium burr, no chipping at all, but it's costly, and we need a space for a FP1 is not easy to do. This is almost FP2 because I reconstructed the harness of tissues here. You can see there, so it's not so easy to use this kind of approach for FP1. You need a highly qualified technician in order to go for it. And you basically have all these options we've been using throughout the years. Let's see what the future teaches us. Of course, I love this, but once again, as I said, I use it for those situations where I want to be sure I will not face a fracture in the long run in this patient with zygoma implants, for example, in several previous treatment. And basically, I wanted to tell you this story, how we overcame the limitations we had around the age of the patient, the condition of the teeth, the remaining bone, the soft tissue quality and quantity, and also considering the number of implants I put and what is the gap size between implants to decide if I segment or I splint the rehabilitation and what kind of material I'm going to use. Of course, the parafunction if the patient is abraxis, you need a stronger framework. So my key points are preserve several teeth, not one single or two, but several teeth if you can, if they have good prognosis. It makes a difference in many patients, mainly in the anterior area. FP1 or FP3 depends on age, preferences, personal preferences, your preferences as well, expectation, vertical dimension, and bone quantity, mainly. And when possible, try to avoid flaps. Be minimally invasive, but sometimes we cannot. We have to raise flaps. Soft tissue grafting boosts the phenotype and minimizes future aesthetic and biological complications. Bone augmentation is necessary in severe defects, will be. And we can get amazing results nowadays we couldn't in the past. Of course, consider the kind of patient you're treating. The more parafunction, the more number of implants and the distribution. And use new devices and workflows to overcome the limitations of digital impressions. Thank you so much. I think it was more or less on time. It was not easy. Thank you so much.
Thank you, Ramón, for beautifully showing the limits of full arch reconstruction so nicely. Our last speaker of the session will be Florin Cofar, who is going to take us on how AI is influencing all our treatment planning in this type of full arch reconstructions. Welcome, Florin.
Thank you. First of all, it's a real pleasure to be here and a real humble moment to share with these two gentlemen and these two giants of our profession, which I really look up to. So I will be talking about AI, and I try to make it simple. I try to make it, pragmatic and always meaningful when we talk about technology. So the simplest definition I can find for AI is that it stands for automation. We use it to make things faster. And we can also use it to solve more complex problems, because normally we come from the age of algorithmic. And there we have many limitations. Now, of course, to make the story more relevant, I will put it in the context of a case. So I also select a case which is, I think, without many words, you can see it's an indication of full arch restoration on implants. And of course, I want to talk about problems, no? Because at the end of the day, technology only exists if it can solve problems. So I chose a couple of them, let's say more or less chronologically how you reach them in the timeline of the treatment. And one thing which we often skip to talk about because it's sometimes tricky is, you know, what do you do with the mock-up in these cases? Because the current narrative is we have to go prosthetically driven. Prosthetically driven means we start from design. And then the problem is you cannot really put a mock-up inside of this patient's mouth. Everything is extruded, everything is out of place, and you don't have like, you know, those nice additive stories. So one of the first, I think, real meaningful uses of AI is, as Howie showed before, nowadays we can use technologies such as smile design. Smile design, in simple words, is also like a philosophical thing, meaning that you start facially driven, you start from the face, but real time makes it that it's also a visualization and communication tool, which is very important because you know, dentistry always starts with a yes. A wise man once said, I think he's in the room somewhere. But generally, you know, it's very important that you have the buy-in of the patient before you move on. Now, this somehow is not enough because we are used to, if we compare to the nice experience that we have in pros, what we want is a real mock-up. We cannot do a real mock-up, but what we can do from a single picture, we can go into smile design and into generating an AI before and after video. So once again, so that is just clear, this right now requires more or less a 3-minute computation, which doesn't require anything to print, works in any scenario, doesn't matter if your patient is edentulous, if its teeth are sticking out or not, and it requires a simple single picture. Now, I think this is on its own a very powerful tool, and I have to again stress the fact that this is not just some random generative that you do not control. You have full ownership over the smile design, over the design, and then the only thing that the AI does is actually enhance the motion and the photorealism, but the design is preserved. I think this is the real powerful thing here. Now, second problem. Fine, we manage the communication, but isn't this too shallow that we base the planning of such a treatment on a single picture? And the answer is obvious. Of course it is. We cannot, and behind the curtain is a very complicated planning process, because I will talk about planning today. Imagine you start from an illustration or a video, and then you have to go into prosthetic design, which of course is usually another software. And then you have to go into implant planning, another software. And of course, most of the time, this will be different people. So you need to connect different technologies and different people. And I'm very jealous of Ramón. If you look at his skills, this is quite unique. Somebody that can do basically everything. I think Ramón is like, is there anything you cannot do? Probably not. But for the rest of us, including myself, I need, always to be the one that coordinates skill sets, because I know my part of the story and the things I can and cannot. And I can tell you, it's not easy to do this connection between the technologies. Pretty much, at least if we go back a couple of years, you would always have to restart the process. So you did something, you sold something to the patient, and then you go into CAD and you try to recreate. But it's not easy. And of course, as anything complex, the devil is in the details. The more details you lose, the more you're off. So I would like, again, to explore some new possibilities, and I would like to talk about something called Blueprint, something that, it's a new, I would say, class of software or technology that we use, which will be available since this October. But outside of that, all I want to start when I talk about digital dentistry, I put this word on the slide, which is Gestalt. It's like a German philosophy that basically says that the whole is more than the sum of parts. This is the best way to describe, working in digital, because at the end of the day, on the screen, you have two elements. You have a scan and a CBCT. But if you put them together, the information that you get is exponentially more. So I think you have two major superpowers in digital dentistry. Putting things together in layers, which creates a completely different perspective of things. And second, and this might sound stupid, but it's not, is you cannot break anything. It's the only part in the treatment process where you can do things, where you can press Command Z, and there is no consequence. Once you exit this digital part, this superpower is finished. So this is why it's important to spend time. Now, the other thing which is important is the segmentation. Segmentation is the use of AI to pretty much be able to identify structures, because once we start to add files and layer and layer and layer, we add complexity. And then again, AI comes in, and we change from files to structures. We're looking at pretty much like a virtual anatomical model, but you can call it whatever you want, avatar or whatever. The point is you can add all of the things here. Now, why is this relevant? Very nice, but why is it relevant? Why do I care? Well, we care because when we plan a full arch, we start, as we said, from prosthetic design, right? So if we start from prosthetic design, what are we looking at? We are looking at a scan, which is a single surface. It's the outer surface. And ironically, it's the surface that is the most volatile in the process. Why? Because it's going to have changes, no? Like the teeth will go out, the tissue will shrink, everything will basically change based on the new prosthetic that will support it. Correct? So how many times did you finish like a perfect surgery? You put the provisional, everything looks great, and after 2 months when the patient comes in, everything is like the tissue is in, and we have this banana-shaped pros that is out. No? That's exactly what I'm talking about. So we have limited information when we plan, because again, what we have to do is we have to guess what happens beyond the tissue, like in the transmucosal part. Think about an FP1. I don't see the alveola. I don't see the bone peak. Is it relevant to see it? Of course. Now, we know that there will be shrinkage. There's many papers on this. I put one on the screen. And basically, even before we used anything fancy, whenever we planned prosthetics, if we didn't plan for a graft, we put the pros in. This is something called like reverse grafting. Means that if you're going to graft, you can put it in the correct relationship to the tissue, support it. But if you're not going to graft, expect a shrinkage, and it's sort of like a preemptive positioning. If you look at the level of the first premolar, that is in this case the only area that we're going to do a graft. Everything else is positioned in to compensate for the shrinkage. Now, what is the alternative? The alternative is, I was just speaking at the time because it's a little bit, okay. The alternative is we use this virtual anatomical model. Now, what does use mean? It means these technologies are very straightforward. You simply add the files, and they will be aligned and segmented and put together. And you have the possibility to work on a completely different canvas, so to speak. Now, at this point, instead of using, the outer surface to plan this case, for example, what we use is two other things which I find very important. You have a real-time visualization of what happens on the face, and you can see the bone, okay? Because what is really important is to position the tooth in the face where it makes sense aesthetically and functionally and all of that, but also to have an idea that it cascades into a realistic implant position. No? Simple example, don't put a tooth on a papilla peak if you want an FP1. And if you're looking at a surface, it's very likely you're not going to see that. So the third problem, which is again very common, how do we handle occlusion? Well, here, this is not an answer for 20 minutes. So I will talk more about the tools and less about the philosophical parts of it. But one of the things in vertical dimension, again, start from the uppers, because look at, this is just an example, okay? In this case, it's a class 2, like Ramón was saying, the easy case that Ramón said, because in a class 2 you have passive eruption, you can change the position of the uppers, and that is the first thing you need to think about before you think about vertical dimension, okay? Now, vertical dimension, many times we just think about convenience for restorative material, okay? But sometimes, I think one very important thing we need to look at is lip sealing. What is lip sealing? Teeth touch, lip should touch with no effort. Because once we have this, we know that the patient will have a good breathing. We know that the patient will have a relaxed physiologic position without muscle strain. And of course, we know that, ironically, you also balance it very nice with the face. Now, lip sealing is not a number, it's a threshold, because when the lips touch, they go into one another. So there's, again, biology comes in thresholds. For example, in lip sealing is probably like 3 millimeters. From the moment that the lip touch until, you have competence, until it goes into hypercompetence, what you see here. Hypercompetence is when you have collapse and the lip go like this, okay, which is like or when you have too much fillers, okay, the same effects happens. Now, splints, you can use splints if you want to validate, but splints, again, you can create palatally supported splints, because in these cases, everything moves in the teeth. Motion data has a very strong combination, because you can generate motion, you can buy a device that does it, but at the end of the day, more important, I think, is to start to use like wider volumes of CT that contain both the teeth and the condyles, because this really gives you a very clear idea. You don't have to guess where's the condyle in these two situations, okay? Because here we have a lot of leeway space in this case in terms of sagittal. You can actually see where the condyle is, and you can, take like informed decisions. Now, even though you can do all of these things, first of all, what is really amazing, that a case that looks, in the beginning, you think this is irreconcilable in terms of an FP1. But if you put all the details together, you realize that you can actually do an FP1 here. Now, the other thing is implant distribution. Implant distribution, I think, and I will not go into a lot of details here, but I will mention a couple of things. Nitzan was talking about having it splinted, and I'm sure, by the way, if I have an opinion and Nitzan has an opinion, better listen to Nitzan, probably wiser on the long run, because he has 3 times the amount of experience. From my end, I try to use critical thinking many times, okay? When you cannot solve a problem, critical thinking. Because I spend a lot of time, for example, with engineers, and I see that dentists, when we have a problem, we zoom in, and I see engineers, they zoom out in solving the problem. What I want to say is that the real problem is not precision. There's many workflows that achieve precision. The real problem is that you cannot capture in current technology one attribute that biology has. If you zoom out, you notice that. And that is elasticity. You can capture very precise a frame in a moving parts, in a moving, things are moving, whether it's the lower jaw, whether it's the upper jaw, less, but it does, whether it's time, the actual, passive eruption that we have as the patient ages. We cannot control all of these things. What does it mean? It means 2 things. The longer the span of the scan, for example, the higher the imprecision. This is just mathematics. The more of error we put in, the more tension in the material. And then, of course, what will happen? The weakest link will break. Now, what I want to do is to design something that is more forgiving. This is why right now, if you ask me, maybe in 2 years it's going to be different, I prefer to segment. To place the implant in such a way that you convert the case from a full arch into 3 or 4 unit bridges or whatever. The point is, we know from the literature, the shorter the bridge, the higher the success rate in terms of longevity. And very important, space between components. FP1 is about papillas. There's no papillas if there's components there. Okay, so again, this step, they are very much, you have to synchronize them pretty much. And the last thing, which is very interesting, I want to show again something cool as we go to the last bit. You can say, yes, but my technician used this or that and doesn't want to do, we developed something called signature design. And again, this is just to, highlight the ownership that should be in the technician. Meaning that now you can design anything in any software, and then you can import it. You can put it on the screen. You can take like a picture of the patient, the scan of the patient, and whatever you want a file as a design, okay? And 2 things will happen. We will put it and make it like photorealistic, as if you would create a mock-up. In many cases, in a scenario where you couldn't do a mock-up in the first place, we would create 2 videos and a 3D scene for you to view. At the end of the day, it's about being able to connect not just the people, but also different technologies and allow this creative freedom that is, at the end of the day, I think, very, very important. And now, looking at the time, I will go very fast on the execution side. What we used here is there's this paper from the concept from David Noret, Violat. I'm sure I don't have to explain too much. It's the acronym for set 3 acceptable retentions. And the surgery here, like I said, I'm not Ramón, so I need my own Ramón every now and then. So I have Venci Stanko, very talented surgeon from Bulgaria. So he was doing the surgeries. And again, because I consider this case as being pretty much multiple bridges, I use intraoral scanner, okay? Now, you can see here that you have the graft only on one side. This is the immediately after. And what I want you to see is how the tissue behaves, because again, everything we use the pros to drive the healing. So what happens is the prosthetics will be the one that will guide all the healing in this place. And you see that when we start, everything is in, and you will see how it will evolve. So then again, the scanning, instead of taking everything out, I just cut the distals of the last pieces, and patient comes in, and I just scan for 2 bridges, and basically it's like 10 minutes, okay, because intraoral scan. Then you mill, then you call the patient back, you put the posterior ones, you take the anterior, and again another 10-minute session without fearing collapse or anything. You treat it as if it's separate bridges. And it brings a certain simplicity and forgiveness to the process. Now you see, when it heals, you still have shrinkage. It's expected, of course. But then again, it's being guided by the prosthetic piece, okay? And because of how this is done, and because of the palatal position of the implants, here I put a paper from Nizan, which long ago described this, even in these profiles, you see this banana pontic in popular terms, where you see you have a more horizontal profile with just a little bit to create this, because we only need an illusion of emergence, okay? But the real gain that we get from this horizontal profile is the fact that when we start to have shrinkage, the shrinkage will follow the prosthetic piece. So instead of going vertical, it will always be horizontal. So it's much more manageable. And then you can see the lab, very simple in terms of how it is done. Remember, we have one prototype in the very beginning, and we have one prototype at the end. And actually, all the shapes are the same. The only thing you adapt is if you see in this previous picture, is just when you have a certain shrinkage, you're going to move the blue to the red. And it's, yeah, I think it's pretty much a way to simplify things. At the end, we have a nice result. We look in time, and I want to show you the real thing about looking at things in this way. Of course, in time, one of the mistakes that we made here is as we moved everything up to really create the conditions of an FP1, because it's always easier to go with the pros to the tissue than to do what Ramón is showing, than to graft. The problem is we went too much in the mucogingival junction, so we didn't have a lot of attached tissue. So you will see after a while, as a maintenance, we had a little bit of not recession. You just have shrinkage, but it only goes in. But having this design, so easy to take a piece out. You can add tissue, put it back. It's very forgiving, and I think this is what I see as a sign of me aging a little bit, because I start to think long term. In the past, it was more about just having the nicest result at the end. Now it's more about thinking, when the problems come, how can we make it better? This is after probably like 2 years, and yeah, this is the final piece. So I think I was pretty close with the time, so thank you very much.
Thank you, Florin.
Thank you.
Thank you for a beautiful presentation, magnificent mindset that you have. We've got some questions that we'd like to share with you.
But let me ask to the three of them one very simple thing. You all showed cases with what we would say terminal dentition. And you never used the teeth to support provisional restoration that could help in the diagnosis or also in the surgery. So do you ever consider this?
Good question.
Whom do you want to
Who do you want to address it to first?
You go ahead. Nielsen, you can start.
Yes, of course we use strategic teeth as interim abutments. But when you have 20 minutes to cover something...
No, but it's fine. It's fine.
25.
It's fine. It's okay.
No, 5 I stole from you. It was 20.
So
yeah, we use strategic teeth for sure.
Yeah.
But look, today when you know that the success rate of full arch, of immediate placement and loading, when you have the right conditions and you work meticulously, are as high as what we used to do with staged approach. I think that for the patients, it's much easier to go directly if you can. Mm-hmm. In the past, of course, we didn't have other choices.
But Nielsen, my question was a little bit on the diagnosis, because we heard Florin, and he showed us beautiful softwares that are able somehow to show the patient the final result. Well, if you use the teeth, you can do this in an easy way, and maybe you can adapt and change.
So I can answer that. So first of all, this particular case, everything is moving.
No, yeah.
This is the real problem in the case. But second of all, and very important that you ask this question, you can never skip the prototype. The only question is, what prototype are you going to use?
Okay.
For example, if everything is moving, you probably notice in one of the slides there was an anterior platform.
But I see your point, but I think it's important for the audience to understand
that you can never skip the prototype.
That there is also another way.
Not always.
Not always. There is also another way.
What do you say, Ramón, about that? Do you ever use transitional teeth extraction or not anymore?
Yes, I use it when I have to go to do bone augmentation, big bone augmentation. When the situation is critical, for example, I have cases where maybe to maintain the old bridge is not feasible, but I maintain it in the anterior area. Maybe I remove it and I prepare a provisional because I'm doing vertical bone augmentation or I'm treating severe defects in the posterior. Then when my implants in the posterior are osseointegrated after the bone augmentation, I remove everything and the productivity is much higher because my implants are osseointegrated in the posterior and the ones in the anterior are immediately placed. And then I load everything with the mild temporary restoration. So that's the situation where I use that, but as Dr. Richacho said, in 20 minutes, I had to cut off 90% of my slabs.
Following up on that, you obviously, all of you three, use smile design in one way or the other. And I saw Florin's concept, which you're always thinking ahead of time, and the way you can take an image, convert it into real life and plan. It's really magical and amazing how you've managed to get there. Now, my question is it not sometimes a little bit difficult to achieve what you're promising on those images and on those videos? Just to put it on the harder side. I know
so here, I think the answer is very straightforward. You should only design what you can achieve. That's no other way to put it, and there's very little, mechanism to safeguard the ethics. But I think at the end of the day, our profession, as a service profession, sells promises. No? We sell a promise before we charge the patient before we do these things, and whether we communicate visually or whether we do it by words, it's the same thing. And I honestly feel better to somehow force people to commit to something than to not commit to anything when I think about the patient. So I think it's better for the patient that there is a more clear commitment from the dentist as opposed to not being.
Makes sense, but you are putting a word of caution there to people.
Yes.
Only commit to what you can actually do, and not
Yes.
what the machine can show you can do.
No, you can commit to what he can do. So it depends. This is very important for the young audience here. Sometimes you need to know your limitations, but you need also to recognize that there might be some other people that can do things that you cannot.
Absolutely.
So referrals are very valuable even today. Yeah. It's not a one-man show.
Okay. One question that came from the audience. We have this beautiful hub here that brings us all the comments from our colleagues there. What do you think in this kind of situation, full arch restoration supported by implants, about using tissue-level implants? Because I heard that, for instance, Nitzen is concerned about going deep with a connection, while I heard different point of views from the colleagues. What is your opinion?
I didn't hear any different point of view. Nobody can argue with that. If you place the prosthetic platform close to the bone, it's wrong. Try to be as far as you can. If you can do it with a single tissue-level implant or with a customized tissue-level implant, as I showed, do it. Of course, for the longevity and for the biology and for the health of the tissues, there is no discussion about it.
Okay.
The fact is that many dentists, especially restorative dentists, are stingy. They don't want to pay the transmucosal components. And many technicians don't understand how to work with them, which is another problem. But biologically thinking, there is no discussion about it.
Thanks a lot for the comment.
Another question here, Nitz and Ramón, both of you covered beautifully biological and biomechanical aspects. What is the most, or you would say, the take-home message on what it is that you have to avoid or prevent to have long-lasting implants that don't suffer for perimplantitis in this type of cases? What is it that is a must-take-home message?
Ramón, you start.
Whether it's soft tissue, biomechanics altogether.
I heard once that there are 100 different determinants influencing the long-term result. So that's summarizing, but of course, for me, if I have to pick up one single, could be implant position. Implant position, the most determinant, because once you change the implant position, no matter how good you are, or if you use custom abutments, you have to change the emergence profile in one way or the other. Everything becomes more complex, more expensive, and for a full arch even worse, because if the because you don't have the possibility you have for a single implant. You know, customizing, I mean. You should go throughout a multi-unit apartment, as Dr. Lichacho said. So that's the one I would pick up. But I think we keep learning, and there is honestly around 100 different determinants influencing the result in the long run.
Well said. Nitsan, do you agree there? Any comment on that?
Yeah, I think that position, number of implants, when you talk about full arch, the spread of the implants, for me, the compliance of the patient is very, very important.
Especially those cases that we come to us with a destroyed dentition. This is not by chance that happened. It's because they did not take care. And it's mandatory to enforce that they need to change their attitude. Otherwise, whatever we do will fail.
Yeah, well, you need to convert their dental DNA or IQ and to make it much higher, because they come like morons in terms of dental IQ, and you are going to place their implants, and they think that the implants are the panacea, no need to, no decay, no nothing, and this is very wrong. So I believe that it is not so sexy and fancy when we talk about teaching our patients, but the time needs to be there.
Thank you, gentlemen, for a wonderful afternoon and all your expertise. Much appreciated. Thank you.